All right, I meant to take off the first part.
Okay, that's all right.
It makes it less stressful.
All right, so Courtney's presenting, Heidi's discussing.
Oh,
Dave-
yeah. Oh, I'm
Direction
discussing.
of- Yeah,
Kim.
Kim, sorry. Kim. My fault. And then, all right, Kim's discussing, and then, David, you have to supervise this one, but I'm gonna jump out.
What?
You have to proctor this one.
Okay, yeah, sure, of course.
Okay, go ahead. Okay. Thank you,
So-
Courtney.
Yeah. So here we have a 47-year-old male. He has a complex eye history. We'll get to that a little bit later, who came in with blurred vision in the left eye that's been stable. His past medical history is consistent with hypertension and anxiety. He is on a cyclovir, losartan, ibrutinib, and then a multivitamin, as well as Bactrim and lorazepam. His visual acuity in his right eye is 20/20, and in his left eye is 20/40.
Oh, okay. So we have a fundus photo of the right eye. The media appears clear, the vessels, there's some mild tortuosity there. And the disc looks pink, sharp, and flat, but it does have a large cup, 0.6.7 or so. Attention is drawn to the macula and the periphery. There appears to be quite a few white lesions. It's suspected cotton wool spots, and then hemorrhages in the kind of peripapillary area.
Are you able to see my mouse if I circle? Okay. Yeah. So I don't really have anything to add to that, just some hemorrhages, looks a little intraretinal there, and then all those white spots kind of around the disc and the superior and inferior arcades there.
It's interesting, if you guys have a really good memory, if you go back to that slide. Last month, when I was lecturing on retinal anatomy, we talked about why the cotton wool spots form exactly where they are in this picture. So they tend to be, if they circle the nerve in this funny pattern. Does anybody remember why they form here?
Very popular.
Yeah, go ahead.
The very popular network.
Yeah, radial peripapillary capillary network. So there's a radial peripapillary capillary network, which has fewer anastomoses than the other capillary networks. And so they tend to form at the end of the radial peripapillary capillary network. So if you see cotton wool spots and you're not here, then you have to be a little nervous. So like if you have cotton wool spot there, that's not right, or over here. But these cotton wool spots are just typical radial peripapillary capillary network cotton wool spots.
All right.
And so fundus photo of the left eye. So the media appears clear. Looks like loss of some of the vasculature, especially in the nasal portion of the nerve, or excuse me, of the retina in general. Looks mildly tortuous in the remaining kind of temporal portions. The disc looks, I would still say like fairly pink, sharp and flat, but a large cup on this side with some temporal kind of loss of the rim. And then the macula looks like a kind of hypo pigmented area. I'm not sure if that's artifact or like a exuded or a juice in there.
Yeah. I agree. The nerve looks a little bit pale to me as well, but that's pretty much the only other thing I noticed.
The vessels are a little thin.
Yeah, the vessels are attenuated. She mentioned that, and then a little bit tortuous as well, especially over in this area we were talking about. And then up here superiorly as well.
Okay, so this is, I think, an IR of the right eye. So it looks fairly unremarkable.
That's what I thought as well. Yeah. All right, so we'll move on.
Okay, and then we have the left eye here. So attention is drawn to the nerve. there's a large area of, I guess, hypofluorescent,
Hyperreflection.
hyperreflection, and hyperreflection in the nerve. I don't know if you would add
Is that
it.
actually the
You can say-
lamina corposa?
You can say
actually
it's a
see it?
real, you can say it looks like a really deep cup.
It does, yeah.
Yeah. Okay,
Okay.
anything else?
The only thing, I thought the macula looked a tiny bit like more hypofluorescent, I mean, compared to the other side, but that was the only real difference that I noticed.
Yeah, not
Yeah,
much there. I should have.
Yeah, okay, yeah,
You said
these are not super, these are not critical. Next, we can go to the next slide.
Okay.
Okay, so we have an OCT macula of the right eye. It looks like for the most part, the foveal contour is okay. It looks like there are some hyperreflective kind of foci throughout like the middle and the inner retina.
Well, what are those?
Most
of those?
Like just pigment.
That one, not that one, the other one.
one's the shadow.
These ones right over,
okay.
right over here.
Yeah.
Those are
vessels.
vessels.
We're both driving the point. This one, right? Like, what is that, the vessel?
Rhymes with
This
mud
is
chestnut.
this is a vertical cut. See, the line is greener, more green, right? And the arrow's at the top. So the top of the arrow corresponds to this over here. So if you look at this little one and this little one that's shadowing, those are normal. Those are vessels. Yeah.
All right.
How come you don't see a corresponding one on the other side of the fovea?
On the top, because the vessels are not perfectly symmetric. This right here is a vessel. You're probably seeing that right over here.
Oh, okay.
And then you don't really cut another big fat vessel like these two when you're going up.
Got it. Okay.
Now, this one you pointed to initially, that little hyper reflective focus is probably abnormal, but that's like 0.5% abnormality in this cut.
Mhm. Okay.
And then here's just, oh, sorry, go ahead.
Horizontal cut, good or bad?
So that looks, for the most part,
Good.
okay, yeah.
Excellent. Next,
Yes.
the next.
Okay, so we have now of the left eye in the vertical cut, you can definitely see those vessels and the kind of shadowing. It also looks like there's some kind of like hyperreflective material right in the fovea and maybe along the, it's like
So-
like RNFL.
So
or
this
eye
is bad in general. Why is this OCT less normal than the other one?
What's missing?
Yeah,
line. Like the foveal, good foveal contour.
that's pretty good. That part's okay, more or less.
I guess you see like the ISOS junction in the middle, but you don't see it extend
Right,
out.
Yes,
Very good.
exactly. There's extensive outer retinal atrophy except in the very center. And that's why these are more prominent. See that this is still the same vessel sort of stuff
Mhm.
that you see, but the retina is super thin. So those are more reflective because the light is not having to pass through all that annoying retinal tissue that attenuates it. And that's why your choroidal pattern is so much more prominent and well imaged because you're getting a lot more transmission to the choroid, so you can actually see the choroidal vasculature because there's substantial clinically significant loss of the outer retina. Let's go back to the other vertical cut just to show the difference. One more back. There you go. One more forward. One more back. There you go. Vertical cut, horizontal cut. Next slide. Vertical cut. Just so skinny.
Mhm.
Yeah.
And
You
then
can see a little bit in the other eye. There was
a little bit, yeah. Let's go to the other. Let's go to the other. And I don't know if you saw it in the other eye there. I don't know if there's any outer retinal loss on the side. Maybe over here.
Yeah.
Yeah, a little bit over there. I see that. Yeah, ratty over there. I'd buy that. Next slide. Next slide. Next.
Definitely more
Horizontal.
prominent in the left eye there.
So there's no horizontal cut for the
No.
left eye. Okay. Okay. All right. Was that good? Do we see that? Okay.
Mhm.
Good. Excellent. We can go on.
Okay, so we have, it looks like FA, like the pre-arterial phase. It's pretty early on.
Mhm. And then I'll go through it a little bit. What I want you to pay most attention to is the timing down here on the bottom between like the choroidal phase and the arterial phase.
I can't
We
really
kind
see the
of lose it on our
timing.
view. I'm trying to figure out how to fix that. the timer, you might have to read it to us.
Okay, so right here, it's about 15.27,
Okay.
16.75,
Look, I don't know how to do that.
18.34, 19.48, 20.62, and here you can kind of start to see a little bit of the filling there. But that's been several seconds now, almost was it 4 or 5 seconds.
And when does your choroid fill?
In the first like 8 to 11 seconds or so. So definitely delayed.
We're gonna hide the video again.
Yeah, I think that's what we can do. Yeah.
No, all right, we're gonna mess it up. Okay, keep going.
Okay.
Complicated.
Too complicated.
And then this is essentially the end of this eye.
So,
Want to talk about what you can see?
Yeah, so there's or especially around the nerve, there are areas of hypofluorescence that seem to remain the same size. And then there are also areas of hyperfluorescence that appear to enlarge over time with some blurred margins. So I think it would be leakage in that situation also.
And then the circulation. Okay, all right.
And definitely delayed circulation.
And if you look all around, I try to look at it as a forest, you know, is there a normal transmission through the outer retina up top?
No, it seems like that's the area where there was the arterial narrowing. that kind
It's
of
weird, right? There's
nasal
like, it's like,
area.
it's beaten up. The outer retina is beaten up. Okay, good.
Yeah, and then areas of leakage over here, like you said, and the macula as well, the vessel attenuation, and then usually like the delay between the choroidal filling and the arterial filling should be like a second or so. Here it's several seconds, so likely there's narrowing of the central retinal artery. And here's just the recirculation phase here.
That's an ultra wide. So that image is a super duper extra ultra wide. Mostly again, looking for non-perfusion. Usually when I'm looking in the periphery, which there isn't exactly there. See that temporal vessel is kind of goofy looking. If you get over temporally, it sort of splays out and circles back. When you get in the far periphery, you can see that sort of stuff. And I don't know, I don't think that's the thing about peripheral imaging. We never could really do it before. I think that's normal. It's just a funny looking peripheral vessel.
Would you say that superior part is perfused though?
Yeah,
Yes.
perfused but beaten up. Yeah,
Okay.
yeah.
You're seeing RP abnormalities.
Yeah, that was the interesting thing about it.
This guy's got a super complicated history.
Yeah, there didn't appear to be any like decreased perfusion, even though the vessels were so small and the filling was very delayed, which is interesting.
And there is a leaky area in the near the center of the macula, the parafoveal, juxtafoveal, yeah, right down there. Yeah.
All right, and we're gonna move on to the other eye. This one has less images. Okay, we only have 3 here.
So there are I've put a few areas of the hypofluorescence, kind of in that like superior arcade, inferior arcade near the nerve portion, which I would imagine will correspond to those areas of heme. And then also some hyperfluorescent areas towards the end of the arcades.
Yeah.
So the hypofluorescence, there's 2 causes, right? There's either
Like the vascular defect and then blockage.
good. And what do you think those are?
I would say those are. I thought initially there was heme there, but I think I'm confusing with where the cottonwool spots were. So I think the window or the vascular.
I think they're cotton wool spots.
Oh.
But it's interesting with cotton wool spots. I don't know.
They're-
Sure.
They don't perfuse, but do they block?
Classically,
We
they're
can
not
go back to the first image so you can see that right where they are, it does correspond.
block, but they can
They
block.
block a
They
little
can
Because it's
block
like
a little bit.
transitate, right? It's just
Yeah.
a little bit of
Yeah,
fluid.
they
So I
can block
think
a
it's
little bit.
both.
It's a little bit
So
of
both-
non-perfusion and a
Yeah,
little bit
the
of
cotton wool
blocking.
spots do show up dark on floors.
They show you right, they show up dark.
Yeah.
How about the ultra wide? Anything strikingly different there or not really?
What's the same? It's the, I guess, FA. It looks like it's perfused down the periphery. You
Mhm.
disagree?
Yeah,
Yeah,
no, no perfusion.
Yeah, everything looks good, and you can still just see those areas of blocking there and then some leakage areas here as well, but everything looks pretty well perfused in both eyes.
and anything leaky or not leaky? Go back one, leaky or
Looks
not leaky?
leaking over here, and then on the superior and inferior arcades looks a little leaky.
Where is that?
You can see it better in this image.
Yeah, I don't think those are leaking. Go to the late one, 2 clicks over to the right, one more click. Yeah, those are more stainy than leaky. Maybe a little bit leaky, but in one area above, like supratemporally, but mostly stainy there.
Okay.
The leakiness is associated with the cotton wool spots. Just temporal to the optic nerve is the most leaky area, but none of this is profoundly leaky.
You see how the nerve stays dark, not to get back to the last case.
Mhm.
Yeah, that's a pretty normal nerve
Yeah.
color.
Your nerve's
for a
supposed to
late
stay dark.
more or less. Yeah.
Right, and then we have our summary of our imaging findings. Would you like to summarize it? I kind of gave you a little cheat sheet here.
You can read it if you want.
I'll read it, I guess. It's right in front of me. So the right eye, several cotton wool spots, retinal heme. FA showed that area of hyperfluorescence consistent with RP damage and hypofluorescence due to the cotton wool spots with that blocking, and I guess also the vascular defect. Left eye had some optic nerve pallor, vessel attenuation, definitely. RP abnormalities, delayed filling between the corneal filling and the arterial filling. And then sounds like, I guess, had a prior BRAO or CRAO in the past.
Or something in the past. Let's do differential diagnosis.
So if we are kind of breaking it up based on the findings, so if we have just intraretinal hemorrhages, I think you had mentioned he had hypertension, so hypertensive retinopathy. I don't believe he had diabetes, but you could always consider that if
Diabetic
he's
retinopathy,
like a vasculopath.
Yeah.
I saw the slide in the beginning of radiation retinopathy.
Yep. Always, you can always mention it to buy yourself time. And anytime you say diabetes, you can also say hypertension and radiation.
Mhm.
And you can buy yourself time. And the last one of the big 4 would
Like a
be
leukemic.
so like you could say vascular occlusion, you could say venous occlusion in the right and arterial occlusion in the left or something like that. Then you have pretty good differential.
And then in terms of, you could bring it up also like the cotton wool spot, which would have a similar differential. And then that like optic disc pallor, you could say like glaucoma, you could say like a ischemic optic neuropathy. That's pretty good.
Yeah, that's good.
That's a passing differential, yeah.
I'll give you a little bit further of his medical history, and then I'll talk about, there's a couple other additional things I had on the differential diagnosis. Does this information, the fact that he's had radiation for several sessions, history of primary ocular lymphoma, as well as some intravitreal methotrexate, does that push you to one diagnosis more than the other?
So like the radiation retinopathy.
Yeah.
Nice. Yeah, we talk about it all the time, but this is one of the best cases I've seen.
And it's scattered in his right eye.
Yeah, it's
I thought that was interesting too, that it was, he had primary ocular lymphoma of his left eye, and then kind of the more classic findings were in his right eye, and all the research that I've done, the cotton wool spots, the flame hemorrhage.
Lymphoma in both eyes at some point. He was sorry, that was a mistake on my part. So he did have lymphoma in both at some point.
Gotcha.
The left eye was a lot worse, but the right eye wasn't wrong, I think. This guy's been presented.
So some of the differential diagnoses, which we talked about, are diabetic retinopathy. And in all my researching on this, it says basically that radiation retinopathy, it's kind of most commonly similar to diabetic retinopathy. BRVO, CRVO, hypertensive retinopathy, ocular ischemic syndrome, and Coates disease. So we pretty much talked about all those, so very good. So, and then the diagnosis in this case is radiation retinopathy. which sorry, I gave that away in the beginning. I meant to change it to case conference and I forgot about that. So going into some of the risk factors and etiology of it, it's a rare but serious complication of radiation, and it most commonly occurs when treating ocular tumors, uveal melanoma, or head and neck cancers as well. It can occur months to years after radiation, but the average is 18 months, and BCSE says 18 months, so that's probably the number that I would remember for OCAPs and boards. And then the risk of radiation is proportional to the dose of radiation to received. So 30 to 35 gray units, according to BCSE, is usually required to induce clinical symptoms. However, some studies show as little as 15, and then some studies say as most as 60. But 30 to 35, again, is probably the number I'd remember because that's what BCSE states. And then BCSE also states that on average, 50% of people receiving at least 60 units and 85 to 95% of people receiving 70 to 80 units have shown radiation retinopathy. And then increased risk is not only associated with the dose of radiation, but how much of the retina is radiated. So greater than 60% has increased risk, as well as the proximity to the structures of the eye, like the optic disc or the macula. And then, was someone talking? Sorry.
No, was this
Okay.
the command center talking?
Gotcha. So some comorbidities that have been shown to increase the risk are diabetes, hypertension, systemic chemotherapy, which our gentleman had both hypertension and systemic chemotherapy, pregnancy as well. The thought with the diabetes is basically a cumulative effect of parasite damage associated with the diabetes and then endothelial damage seen with radiation. Diabetes has also been shown to have poor visual outcomes because they have a higher risk of developing neovascular changes associated with the radiation retinopathy. And then some risk factors for developing proliferative radiation retinopathy include younger age, diabetes, and shorter tumor distance to the optic disc. Interesting thing about the radiation retinopathy, kind of both like diabetes, you can have proliferative or non-proliferative. So some of the pathology, usually you have sparing of the parasites. Usually it has preferred loss of endothelial cells first. The studies have shown that that's basically due to more free radical production because they have a higher oxygen and iron content, so increased production of free radicals there. And the radiation can also cause direct damage to molecular bonds through DNA base pairing damage. The endothelial damage then can lead to the microvascular occlusion, progressive capillary loss, and lead to ischemia and non-perfusion, which can increase the expression of VEGF and lead to some of the clinical findings that are typically seen, like macular edema and neovascularization. So clinical presentation, usually it can be asymptomatic or have mild visual disturbances like seen in our case here. You can have metamorphopsia, floaters, and in some cases scotomas. As the disease progresses, you can have more severe vision loss. And then severe cases can also lead to neovascularization, vitreous hemorrhage, tractional retinal detachments, and neovascular glaucoma. And as I said a little bit earlier, it can be proliferative or non-proliferative. An interesting finding that I found is usually a good kind of rule of thumb to differentiate it between diabetic retinopathy, obviously besides taking a good history and seeing that someone has had radiation, is that it's usually like unilateral. I mean, it can be bilateral like in our case, but unilaterally, and then fewer microaneurysms in the case of radiation retinopathy compared to diabetic retinopathy as well. So for diagnostic evaluation, obviously you want to do a good dilated exam, and you can see typical findings like microaneurysms, retinal hemorrhages, some exudates, edema, cotton wool spots, neovascularization, vitreous hemorrhage, or tractional retinal detachment, optic disc edema, and RPE atrophy.
Oh, you're breaking up.
The overhead.
Oh, there you go. We heard
Yeah.
you. We lost you for a second.
Oh, sorry. So FA is also another good tool to have just to check for areas of capillary non-perfusion. And that's usually one of the most consistent findings in radiation retinopathy. You can also check for microaneurysms, hypofluorescence from retinal hemorrhages, and then leakage due to perivascular sheathing, some exudates, or retinal or optic disc neovascularization. OCT is also good to help for checking macular edema or any type of retinal thickening that can be seen. Macular edema has been shown to be seen in as many as 33% of eyes with no clinically apparent retinopathy. So it's a good kind of screening tool for radiation retinopathy to check for any type of macular edema. And then macular edema on OCTs can manifest almost 5 months earlier than any type of clinically detectable retinopathy. And then B scan as well to evaluate for any type of those retinal detachments that might occur if you have concern for that. So treatment. So interestingly, there's no FDA approved treatments for radiation retinopathy. Most of these are off-label use. So going off the same mechanism that this endothelial damage leads to ischemia, non-perfusion, and elevated VEGF, anti-VEGFs are kind of one of the mainstays of treatment. And many studies have shown improvement in macular edema following the anti-VEGF injections. Though similar to like diabetic retinopathy or wet macular degeneration, you're going to need usually several injections. And visual acuity in some cases has been found to be improved, but in most cases, it's not significantly improved.
Sterile code-wide, vaccine system, hospital-wide, cancel code-wide, vaccine
That's just the
system,
overhead.
hospital-wide.
Okay. And then intravitreal steroids are also something that can be considered for their anti-inflammatory effects. Triamcinolone as well. The dose they said is 4 milligrams per 0.1 ml doses. They transiently reduce macular edema and help to preserve visual acuity. And then PRP as well in the periphery or focal. Limited, that was kind of the older treatment before the VEGFs came out and the steroids. It seems like the steroids and the VEGFs are more of the mainstay of treatment now rather than PRP, but it is still something that can be done. Most of the studies show that it doesn't significantly improve visual outcomes. So still done, but not quite as commonly, it seems like, as the VEGF or the steroids. And then in some severe cases where you would have, severe vitreous hemorrhage that wouldn't resolve or any type of the detachments, you can do vitreoretinal surgery. Hyperbaric oxygen therapy is also something that has had limited evidence on, but it has been investigated. Basically involves the administration of oxygen at high pressures and hope to increase oxygen delivery to hypoxic tissue. And it's thought to improve perfusion to the damaged vessels.
Interesting. Some ocular oncologists endorse pre-treating patients after they have radiation, either external beam or through brachytherapy, with anti-angiogenics before they develop radiation retinopathy to delay the onset. It's like if you have a diabetic and they're going to get worse, would you pre-treat them? I don't think there's level 1 evidence for that, but it seems to be a pattern that I have observed and participated in. If I get referred a patient from an ocular oncologist who's getting an anti-angiogenic every 2 months and they don't have any detectable radiation retinopathy, I generally keep it up. You do that?
Yeah, I'm not crazy about it, but I do it.
Yeah, I'm not crazy about it either.
Kind of hold my nose.
Yeah.
I don't think it does anything.
It may not. We don't have any ocular oncologists in Tampa Bay anymore.
Well, you guys, what happened? The guy
Yeah,
just
Dr. Aji.
Is he
got
doing
it?
that? Is he doing all?
Yes,
So this-
ocular oncology and orbit. I
So-
don't know if we set it up to handle the radiation yet. He's not doing plaques yet.
That
but he
must be
does
it.
that.
Yeah, it would be
Because I
good.
tried to get people over and he said
Yeah.
you can't quite do it.
It would
yet.
be good to ask him if after a plaque or after external beam radiation for a lymphoma, what's his opinion on on treating patients immediately with anti-angiogenics forever.
I'll text him.
The Shields have been trying to study this, and I saw him present a couple of years ago. And I don't,
Mhm.
I think all the studies show very little.
Cause it seems like you could treat the leakage, but it wouldn't do anything for the capillary non-perfusion that's gonna eventually develop anyway, right?
That's
It
the
wouldn't
question.
prevent that.
Are you delaying the onset of inevitable vision loss from more than 35 gray of total radiation exposure? And I think there seems there's a trend to do more of that pre-treatment, but I don't know where the evidence is for that, like where the best evidence is for that. I haven't looked.
I guess they would
I
be
haven't
the
looked
people
through
who
it.
study it. I
They would be
mean,
the
that's
ones who
already-
would know.
I
Yeah,
don't think,
you would
last
know.
I saw, they were not enthusiastic,
Not enthusiastic about it.
but that was years ago, 2 years ago.
I think Dr. Roddy does do plaques now. I was with him last week.
Oh, is he still at the plant? Okay, because I've been trying to get people over to him.
That's awesome that we have
I
a
have his name on my
trained
phone.
placker now.
Right.
Yeah.
Well, we are in the community. I'm a trainer, I just can't
You
get
were
away.
trained- Yeah, so
I
Steve
can't
had
get-
plaques for years.
But I can't, I
Yeah.
was in the comm study, but I can't get my hospital to do it. I just can't. I've tried and tried and tried. All right, go ahead. You're doing well. Somebody's.
All right.
I think
I think you have a chat alert.
I turned the sound on.
No,
Is
it's not.
it the chat alert?
Oh, is it a channel or? Oh, God.
I don't
Got a
think
chatter.
he's doing it.
It's too frequent to be a
Yeah,
child.
too frequent to be a chat alert.
All right.
It might be on the presenting doctor, no, on the commenting
All right,
doctor.
so Courtney, go ahead. We gotta wrap up.
Yep.
You're doing a
Okay.
great.
Yeah, prognosis basically depends on the stage, the extent of damage, and the response to treatment. Early detection and intervention, just like in most cases of any retinal disease, offers the best chance of preserving vision. In advanced disease, you can get impairment or blindness, especially if like neovascularization occurs or neovascular glaucoma. The COMS trial, which dealt specifically with brachytherapy, and this statistic right here, reported that at 3 years post-treatment, nearly half of the participants had a visual acuity of 20/200 or worse. So prevention and long-term monitoring, kind of like we talked about a little bit earlier, you can pre-treat. Some people do prophylactic VEGFs or steroids, and that's been shown to have less macular edema and less severe vision loss compared to control groups in a couple of studies that I saw. Also, I saw one case of pre-treating with PRP, which initially had good results, but long-term didn't change any visual outcomes. Shielding the eye if you're doing any type of external beam radiation to head or neck cancers, hypofractionation of the radiation. And then basically you just need good long-term follow-up. They should have regular lifelong ophthalmic follow-up to monitor for any changes of radiation retinopathy and its complications. And then here's references.
Nice job.
Nicely done, man.
Just a general comment, when you're seeing a diabetic patient and you're looking and they have diabetic retinopathy, if you see a lot of cotton wool spots, diabetics don't tend to have a ton of cotton wool spots, so it would just also make you think of hypertensive retinopathy and radiation as well.
Yes, thank you. Sorry, my dog is barking now. It started to thunder and he's terrified of the thunder.
That's scary. Yeah. All right.